Welcome to another one of my series of conversations, and this one is about obesity and its problems. Who am I? Uh, my name is Dr Malik. I'm a cardiologist in London, and I work at One Welbeck. My own NHS practice is at Imperial College Healthcare NHS Trust. This talk was initially given as part of a symposium at Welbeck about obesity. So it is an epidemic, and let's define obesity first. Obesity occurs when your BMI is over 30. For Asians, that's a little bit lower because visceral fat is accumulated when you may not look fat on the outside. If your BMI is over 40, you are morbidly obese and at very high risk. If your BMI is somewhere between 20 and 25, you're probably in the normal range. In the United Kingdom, we're getting more and more obese. This is matched throughout the rest of the world. The Asian phenotype, as I say, is slightly different in that you carry more fat for the same amount of BMI, and therefore a lower BMI will still make you obese. And that is because there is fat on the outside, but then there is fat on the inside. Visceral fat is worse for you than subcutaneous fat. So you may be fit and look fat on the outside, and you may be skinny and are fat on the inside, that carrying much more health risk to you. So what are the problems of being overweight? Well, they are the ones that I can deal with, such as diabetes, high blood pressure, high cholesterol, heart disease. And actually, I often also diagnose sleep apnea, but being overweight makes you more prone to cancer. You have fatty liver disease, which can lead to liver problems, and of course, puts pressure on your joints. So if you do have diabetes, then remember, a non-diabetic with a heart attack obviously has a risk of another heart attack, but a diabetic who's never had a heart attack has that same level of risk. You're already in a high risk group once you're diabetic. What about blood pressure? Well, blood pressure is something that we need to measure carefully to start off with. Normal is between 130 and 85. If you're going above that to about 140/90, you're in the elevated range, but not needing tablets. And if you're above 140/90, then you really need to be seeking some further attention sooner rather than later. But it's not so easy, because it could be that you have white coat hypertension. Just seeing the doctor causes your blood pressure to rise. It may be that you've not measured the blood pressure correctly because you're overweight and the cuff size is too small, giving you an elevated blood pressure reading. And it may be you just haven't measured the blood pressure properly. Avoid caffeine, cigarettes, stimulants, and food for at least 30 minutes. You should take it before you take your tablets. You should not be desperate to go to the loo, because that will raise your blood pressure. I need to find a quiet place. And then when you're doing it, then remember, chair with back support, legs apart, flat on the ground, not cross-legged, and the arms supported, ideally on a cushion so it's very comfortable. Rest for 5 minutes, and then take 2 or 3 measurements, 1 or 2 minutes apart. And here are 3 such readings. Well, which one is the correct one? Look at the systolic, because that is more important than the diastolic, and choose the lowest number, because that's your real blood pressure. So for this person, it would be 130/100. What about stroke and obesity? Yeah, it rises. And if you compare BMI of 20 to BMI of 30, you've got a 50% increased risk of stroke. But why is that? It's because you're more likely to be diabetic, have atrial fibrillation, have high blood pressure, and have sleep apnea. Stroke is best avoided. It's a rule of thirds. 1/3 of strokes are fatal. 1/3 will leave you disabled. And in 1/3 of cases, you'll be lucky enough to recover. So prevention is definitely better than cure. What about atrial fibrillation? Well, atrial fibrillation is definitely more prevalent in obesity, because obesity leads to sleep apnea, hypertension, diabetes, cardiovascular disease, all of which are risk factors for atrial fibrillation. So any treatment that just treats the atrial fibrillation is likely to not succeed in the long term. So we treat all of the risk factors. We decide on whether anticoagulation is needed or not to prevent stroke. It's not needed in all cases. And we decide whether rate control is better, control the heart rate, or rhythm control, return you to a normal rhythm, which requires some more effort and may not be worth it, especially if you're going to be on anticoagulation anyway, you're older and you have very few symptoms from your atrial fibrillation. What about coronary artery disease? That's certainly more prevalent in obesity, and we have to treat all of the risk factors. Here's a stool with 4 legs. Let's knock every leg out. Stop smoking. Get your LDL below 1.4 millimoles per liter. Get your blood pressure below 130/80. Control your sugar. All of these are vital, as well as controlling your blood pressure. Avoid the chippy. So what can you do? You're overweight. How can you get checked out? Well, check for all of the linked risk factors. Get onto a diet and exercise. Let me talk to you about the different diets. My favorite at the moment is intermittent fasting. So, for example, you eat only between midday and 8 p.m. That is 8 hours. You can choose the window that you want, but it's important not to take a single calorie before or after the window, because then your body feels that you're not actually fasting, and therefore it won't produce the weight loss. It's very important to stick to the 8-hour window. You may need to build up to it. You might need to go for 10 hours first, then 9 hours, then 8 hours. But 8 hours seems to be the magic number, and midday to 8 p.m. seems reasonable. All you're doing is you're missing breakfast. So let's try and do that. It really does work. I've had many patients with success. If you can't do that, then try the 5-2 diet. So 2 days of the week, you take very few calories. Normally, you're taking 2,000 to 3,000 calories a day. There is no way the following day you'll eat those calories back again if you've really cut back on the calories on 2 days of the week. You will be hungry on those 2 days. The other thing is to eat slowly. We all rush our food. I've usually eaten about 10 minutes. That's not good. The sugar hasn't gone into our bloodstream. We still feel hungry. Another plate of food arrives. So what you can do is take a large glass of water and chew each mouthful carefully. Chew and water. It's very important. Put the fork down in between each bite. Have a conversation. Time yourself. Take 45 minutes. It's hard, especially because we eat so quickly, but it reduces the calorie intake. Cut the carbs. This is a simple maneuver. Cut the carbs. Rice, bread, naan, pasta, and potatoes are all carbs. If you can reduce those, you will start to lose weight. Here's an example. Cauliflower instead of mashed potatoes. Take more soup. Take lentils, pasta, rice, bread, naan, potatoes, alcohol. Turn to sugar in your blood. So there we are. If you want to know more, then you can check out my website, londoncardiovascularclinic.co.uk. You can check out my YouTube channel. You can contact my private PA at Dr Malik PA at onewelbeck.com. Or if you want to see me on the NHS, I work at Hammersmith Hospital, and you can contact Sharon Kebble. Thank you very much for listening.